Hey guys, it's me again. I've got the chapter 50 lecture here that I'm going to go over really quick. I've got like 20 minutes before I gotta get my kids from school, so I am on a timer. I'm going to try to get through this quick. I only have 10 points on the PowerPoint, so I'll try to make up for the length of the last video. I'm going to share my screen with you guys. Okay, so we're going to talk about problems with the biliary system, which include the gallbladder and the pancreas. So just a fast anatomy and physiology review. We have our gallbladder. That's a pear-shaped organ. It's found beneath the liver, has a capacity of 30 to 50 mils, storage, little storage sac, and it's composed of mucosa and smooth muscle. It's connected to the common bile duct via the cystic duct. And we know the function of the gallbladder is to store bile, right? Sorry, I'm gonna move this down a little bit. Bile is created by the liver and transported via the hepatic duct and then stored and concentrated in the gallbladder. So what does bile do? Bile helps us digest fats, right? Specifically our fat-soluble vitamins. I don't know if you guys remember from last semester, but I gave you an acronym to remember those fat-soluble vitamins. That's when you play cards, you want to play with a fat deck. So A and then deck, D-E-K. So vitamins A, D, E, and K are your fat-soluble vitamins. Patients with obstruction of the bile will have a deficiency in these fat-soluble vitamins because they don't have the bile to break them down, so they're gonna just move on out with the stool and not be absorbed like we need them to be. So with normal digestion, we eat, we have digestion that starts in the stomach and then moves down into the small intestine, into the duodenum. That's chyme. And then we have our gallbladder senses when that fat comes through and is going to contract and release bile down through the bile duct to help digest our fats, right? But what if the bile can't get out of the duct? Then we have a problem. Our fats aren't going to be digested and they're just going to kind of slide right out, right? So we're going to have greasy, fatty looking stools. That's called steatorrhea. That's important to know. If you don't know that term, please write it down, look it up, know how to spell it, know it by heart, because that's a very important assessment, nursing assessment to obtain. So they're going to have the fat just is not going to get digested, just going to slide right out. Common causes of this are stones in the gallbladder, and we're going to talk about that in just a little bit. So what is bile made of? Bile is made of bilirubin and some other bile salts, but bilirubin we know is a byproduct of our red blood cell breakdown, right? And if the flow of the bile isn't working and the bilirubin doesn't get released into the intestines, the bilirubin is what gives the feces a brown color. So we may see our patients who don't have the release of bile and bilirubin have light clay-colored stools. And then what happens to that bilirubin? It gets absorbed into the bloodstream. So we have blood levels of bilirubin that increase. And so we might see jaundice of the skin and the mucous membranes when we have large levels of this. And this will end up being excreted renally. So we can see light colored stools because we're missing our bilirubin that gets excreted renally. So we may see dark colored urine. So if you see light colored stools and dark colored urine, you know we've got a problem going on there, right? So that's a sign that we've got some kind of obstruction in our biliary tract. And then we know we have our pancreas right here. This little cell does a lot of different things that we'll talk about in just a minute, but we have our pancreatic duct and our bile duct, and they meet and intersect to dump all your enzymes right here in your duodenum. And where they meet and intersect, that's called the ampulla of Vader. So you remember those A&P terms that give you nightmares and flashbacks from trying to memorize all that stuff. But here we go, we're talking about it again in nursing school. and they're released through a sphincter, which is called the sphincter of Oddi. So that's important to also know as well. But let's talk about gallstones. So these are the number one culprit when it comes to issues with our gallbladder. So we can have these calculi or these gallstones. They usually form in the gallbladder from solid constituents of bile, and they can vary in size, shape, and composition. So here's just a bunch of different stones. They can be really small, they can be really big. It's crazy what they look like. Pathophysiology-wise, we have two different types of stones. We have pigment stones. These are dark, and these are made from unconjugated bilirubin. That's 10 to 15% of the stones. And the risks for developing these are cirrhosis, hemolysis, and infections in the biliary tract. These stones cannot be resolved. They have to be removed surgically if they're causing a problem. And then the other 75% of our stones are caused by cholesterol stones. So we have an increased cholesterol production in the liver that results in bile supersaturation of cholesterol. And then when it gets put into the gallbladder, the cholesterol and the bile separate and the cholesterol forms stones. So we have those heavy cholesterol stones. And these stones can act as an irritant and produce inflammatory damage and changes to mucosal lining of the gallbladder. So some other causes of gallbladder disease that we can see is maybe the gallbladder is just not contracting and releasing the bile like we need it to. And this can happen in severe endless sepsis. Sometimes those are on parenteral feedings for a very long time, and they don't have that stimulation to release. So you can look at risk factors in chart 51. So know those risk factors and be familiar with those for stone development. Some of the common ones are female, obese, pregnant, Native American, Hispanic heritage are more prone to these as well. So gallstones can be silent for a long time and may produce no pain or maybe only mild GI symptoms until it becomes a problem with obstruction. And the mild symptoms can be fullness, abdominal distension, distress following a really rich meal, like maybe sometimes they'll have a little bit of distension or bloating after eating a really heavy meal that is high in fried or fatty foods. And then if the stones block the cystic duct, the gallbladder becomes distended, inflamed, and infected, and that's when we have acute cholecystitis. So patients are going to develop fever, severe abdominal pain to the right upper quadrant, accompanied by biliary colic, which is pain that radiates to the back and the right shoulder. And then, of course, that's usually always accompanied by nausea and vomiting. We can assess our patient and for the Murphy sign. So the Murphy sign, when you have the patient lay back and take a deep breath. And as they breathe out, you're going to push down and up on the right upper quadrant mid-clavicular line. And if they hold their breath, that's a positive sign. And what that does basically is you're pushing up against that inflamed gallbladder. And when it comes in contact and has that pressure, if it's inflamed, it's going to cause pretty severe pain for the patient. And so that's, we know they've got an inflamed gallbladder, so it's a positive Murphy sign. Stones that obstruct can cause necrosis, abscess formation, and perforation with peritonitis. That would be bad, cause them to be really, really sick. And again, we can have the jaundice that occurs because we have the bile obstruction. The bile duct can become obstructed. So bile is absorbed by the blood and can give that jaundice to our mucous membranes, yellow color. Remember, jaundice causes pruritus and itching also, so just keep that in mind when you're doing your assessment. And we can have those changes to our stools, so the light clay color, the fatty greasy stools, and changes to our urine, the dark colored urine, because bile's not going where it's supposed to. And then we can have our vitamin deficiency with our fat soluble vitamins. Those are clinical manifestations of cholelithiasis. So what's our management? First, we're going to do some diagnostic intervention. So the common diagnostic procedure or the procedure of choice is an ultrasound, and this can detect calculi, so those stones, and also if the bile duct is dilated, so that kind of clues us in. And then the cholecystography, also maybe known as a HIDA scan to a lot of people. That's where we give a radioactive isotope through IV, and then we stick them under that special camera and we look at the gallbladder and the bile ducts and the biliary trees to look and see if we can see stones, inflammation, obstruction in those areas. Another one that's not the first line but can be used is the ERCP or the MRCP, and that's where they go through and do the visualization with the endoscope. So our goals of treatment are to reduce our acute episodes of gallbladder pain and inflammation, support dietary management, pharmacological management, endoscopic procedures, and nutritional information. So nutrition, 80% of these patients with acute inflammation can resolve with rest, IV fluids, NG tube suction, analgesia, and antibiotics, unless the patient's condition deteriorates, like signs and symptoms that we did have that necrosis and stuff going on, then, or sepsis, then surgical intervention obviously will need to be done, but it's typically delayed until the acute symptoms subside, which is usually a few days. Diet immediately after our acute episode. So we haven't done any kind of surgical intervention. We've done the, IV rest, bowel rest, all that stuff. And then resuming a normal diet for them, we want it to be low fat liquids, cooked fruits and veggies, rice and lean meats. Just think bland. It needs to be bland, non-fat, non-greasy, non-gas forming veggies, because when they eat those gas forming veggies like broccoli, cauliflower, things like that, the gas can increase that pain and discomfort for them. So we want them to avoid that. And then they want to avoid eggs, really high fat dairy like heavy cream, full fat cheeses and things like that, pork, those fried fatty foods, those gas forming veggies, and alcohol. So you need to avoid all that in that post-acute phase for the cholelithiasis. Our pharmacological therapy, we can use the ursodeoxychloric acid or the chenodeoxychloric acid. So Actigol or Chinex are those brand names, and those can be used to dissolve small cholesterol stones. And they'll have to be on this therapy for 6 to 12 months for those stones to dissolve, and they'll probably go back in and do more scans and tests to kind of look at them and see how that therapy is working. Non-surgical removal of the gallbladder stones for patients who are maybe at high risk for surgery or can't have surgery at the moment. They can inject solvents to dissolve the stones percutaneously into the gallbladder through a tube or a drain, a T-tube, or through the endoscope, through that ERCP scope. They can also do pulse therapy to break it up. They can do the intracorporeal lithotripsy, which is the mechanical shock wave, or the extracorporeal shock wave lithotripsy, where they use that fluid filled bag or put them in that kind of like a spa with jets to break up those stones. And then if they're really big stones, they can break them up and then potentially go in through an endoscope and retrieve stones if needed. So though there's some different non-surgical management. And then nursing management for these patients, obviously they're going to be NPO in that immediate time period because pain, nausea, vomiting, we need to rest the GI tract. They may require an NG tube for GI decompression. Recovering post-op, we're going to start them on clears and advances tolerated. They don't need to eat a cheeseburger right out of surgery or right out of getting out of this process. We want to avoid those high-fat foods. IV pain medication is big on all these biliary issues, and antiemetics when they have nausea and vomiting. IV fluids are going to be key. We need to keep them hydrated. They may be dehydrated from nausea and vomiting, and we need to maintain their fluid and electrolyte status. Labs, we're going to monitor bilirubin levels, white blood cell count, renal function, because we are checking our fluid status and electrolytes. We want to monitor for signs and symptoms of sepsis and infection and report those. Those might be mental status changes, tachycardia, hypotension, fever, white blood cell count, increasing abdominal pain, nausea, vomiting. So those are all red flags that, hey, we're decompensating here, we're not doing good. Okay. And then laparoscopic cholecystectomy is the standard for management. So that's removal of the gallbladder. We go into the laparoscope. They usually have 3 or 4 laparoscopic incisions, just depending on the approach that they need to take to get in and get it out. So after this procedure, patients may ask, and we need to educate them. We're going to talk about this in class, and we're going to do some case studies, but the bile is going to flow from the liver to the duodenum freely, so there's no more storage space, right? We're taking that gallbladder out. We want to monitor for infection at the incision site, so we're going to watch those incisions. Postoperatively, they can have a lot of times have shoulder pain, and that's because they use that CO2 to inflate with the laparoscope, and it takes a while for your body to absorb that. So they have that like pressure shoulder pain from that CO2 gas. So things you can do to help for that is have them sideline with their knees bent. That can help with that pain. Of course, analgesics. The very best thing you can do for these patients postoperative is early ambulation. Not only does that encourage like gas movement, and they usually, first thing they stand out of bed, they just like belch and burp and move a bunch of gas around and air around, and that helps relieve their discomfort, because the more gas they have, built up, the more discomfort they're going to have. And then obviously we know ambulation prevents surgical complications like bowel, paralytic bowel, and atelectasis, and all those kind of things. So the more you can get earlier and the more you can walk your patient, the better. We want to use incentive spirometer. We want to teach them to cough and deep breathe. They're probably going to have to splint those first few days because it's going to be pretty tender. They may have a T-tube in place in the bile duct, and this is used to drain bile while the duct is healing. And they may have a bag to collect that, and it's usually going to be kind of a greenish color. We want to keep it lower than the level of insertion, make sure there's no kinks while it's trying to drain, keep the patient in the Simmelfowler's position to help promote that drainage, measure it, record it, see what it looks like, report if there's excessive amounts coming out. Sometimes they may give you, as the patient starts to get better and progress, giving order to clamp the tube an hour before and after meals. That way they can have the bile to help digest when we start putting them back on a by-mouth diet. But you have to have physician order to do that. So please look over and familiarize yourself with table 52. That's education on status post cholecystectomy, and we are going to be going over that in class as well. But just please look at it and kind of familiarize yourself with it before class. Let's talk about the pancreas. So we know our pancreas is located in our upper abdomen. It has 2 functions. Has exocrine function, which is secretion of the pancreatic enzymes into the GI tract through the pancreatic duct. These enzymes are very alkaline. They're neutralizing highly acidic gastric juices that enter the duodenum. These enzymes are amylase, which digests carbs, trypsin, which digests protein, and lipase, which digests fat. And then our endocrine function, we have the islets of Langerhans. We have alpha, beta, and delta cells. The beta cells produce insulin, alpha cells secrete glucagon, and delta cells somatostatin. Obviously, we know what insulin does. I'm not going to go over that. Glucagon, somatostatin, you guys can look at those hormones and know the functions of them. So pancreatitis, we can have acute pancreatitis and chronic pancreatitis. Acute can be anywhere from mild to life-threatening. Commonly, the pancreatic duct can become obstructed, and so we have those digestive enzymes that can't drain out through the ducts and be delivered to the duodenum like they're supposed to. So what happens is those enzymes build up within the pancreas, and we have what we call autodigestion occur. So that's when we have the digestion of our own pancreatic enzymes. The pancreas can swell, and these enzymes can also start to leak into the abdomen, and then we have lots of problems. But we can have sudden onset when we have the stones blocking the pancreatic duct, or it can come from binge drinking. So we have like an acute episode of binge drinking, and that can cause a precipitation of acute pancreatitis as well. These patients are going to have extreme pain. I've never seen anybody hurt as much as somebody who has pancreatitis in all my years of nursing. It's going to be mid-epigastric, and it hurts worse than when they lie flat, because when they lie flat, that pulls the peritoneum and puts pressure on the pancreas. So a lot of times they'll just automatically guard themselves. So they'll have, kind of a bent position or a sideline position with their knees up because that's comfortable for them. They can have ascites, so swelling from the pancreas. The leaking of digestive enzymes can cause ascites within the peritoneal cavity. These enzymes then can leak out and they can affect our lungs. They can affect the major vessels. This can cause bleeding, internal bleeding. So that's where you see here the colon sign, because these vessels have become damaged around the umbilicus, and then you're going to see this circle and this bleeding. And then this is called the Gray-Turner sign. It's basically the same thing, but just in a different location. We have damaged these vessels here. So we see the bleeding and bruising from damage to these vessels. This is not good, not good signs, right? We're also going to see malabsorption, obviously, because they're not digesting properly, because those enzymes aren't going to where they're supposed to. They're just leaking out into the peritoneal cavity. Extremely high levels of amylase and lipase, or we're going to see serum high levels of those. And then with the binge drinking, we can see damage to those pancreatic cells as well. The chronic is reoccurring inflammation of the pancreas over time. This can occur from repeated episodes of either acute pancreatitis or years of just continuous alcohol intake. And this can cause irreversible changes to the pancreas. The cells can become fibrous and damaged, and this is not reversible. Amylase and lipase are usually not as severely high. They can be high, or they can even be normal, because the damage has caused those pancreatic cells to become fibrous, and then they just don't secrete the amylase and lipase anymore. So they can have chronic benefic-gastric pain, or they may have no pain, because once they get to that point where they're not making those enzymes anymore, then they're not experiencing the pain. They can have, again, just like we had with our gallbladder problems, the steatorrhea, because we're not digesting our fats like we're supposed to, weight loss, malabsorption, jaundice, and development of diabetes mellitus from damage to those islet of Langerhans cells in the pancreas. So we're going to watch those amylase and lipase labs and expect them to be elevated in the pancreatitis patient. So what's the nursing process? NPO, we gotta allow that pancreas and that GI tract to rest. Anything that you take in is going to stimulate that digestive process and that release of amylase and lipase from the pancreas. We've got to cut off any intake by mouth to let the GI rest. So no stimulation, no extra enzymes. We may also insert an NG tube to decompress, to decrease gastric contents, and to help with nausea, vomiting situation. Once the amylase and lipase start to come back to normal, then they may start them back on an oral diet. Just depends on how severe their pancreatitis is. Again, pain management is huge with these patients. There used to be a debate over morphine versus Demerol. Any opiate can cause spasm of the sphincter of Oddi. So they used to say, well, morphine causes it more than Demerol, so let's give Demerol. But then Demerol also has some negative side effects. We can have those metabolites build up. And so, it's really kind of on the fence about whether you give Demerol or whether you give morphine. Either one is acceptable, but both are still going to cause spasms of the sphincter of Oddi. So it's just whatever the physician's preference is, or whatever that patient feels like helps them more. Some non-pharmacological, again, can be that positioning, so leaning forward and having them sit up versus having them lay flat. And they're also going to be on H2 agonists or PPIs. Those are used to decrease gas secretion, which is going to decrease pancreatic activity. We want to maintain IV hydration, NPO, nausea, vomiting. We need to replace fluids, perneural feedings, TPN needed to maintain metabolism on extended GI rest. Monitor our blood glucose levels because we have damage to our pancreas, which regulates our insulin and our glucagon. Urinary output for fluid volume status. And then again, we're going to look and see, is our urine dark? What's that a sign of? Our bilirubin going into the systemic system rather than where it's supposed to go. If this is a chronic condition, then they may need replacement of those pancreatic enzymes, and those are given with meals to help digest. Diet, we want to teach them to obviously avoid alcohol. abstain from alcohol if possible, greasy, fatty foods, low fat, bland diet, small meals, high protein. So they need to be on. Tumors of the pancreas, we can have pancreatic cysts. Those can develop with chronic pancreatitis. Local necrosis can cause collection of fluid. These can become walled off and fibrous, and these are known as pseudocysts. They may require drainage if they become really large. They can also rupture as well. And then with pancreatic cancer, that's the fourth leading cause of death in the US for men, fifth for women, very poor prognosis and short survival. Smoking, exposure to industrial chemicals, diets high in fat and meat can all be risk factors. You can look at those risk factors for development in your textbook. The problem with pancreatic cancer is it usually only appears once it's pretty far progressed, because it's just generalized symptoms until it gets to that progressive stage. And then we have pain, jaundice, and weight loss. But usually once they find it and diagnose it, it's pretty far gone. And the problem is these malignant cells can often shed into the peritoneal cavity, and that makes metastasis very common. So it's very, very hard to treat. Like I said, poor prognosis and short survival. CTs are used to diagnose. Total excision is often difficult or not an option. Extensive growth of the tumor before it's found, and then probable widespread of METs makes it very hard to manage. It can be attempted to treat with radiation and chemo. They can also do a Whipple procedure, and that's where they'll go in and remove the tumor. The end result, the resection of the carcinoma, and they take the head of the pancreas or the ampulla vator. The common bile duct is sutured to the side of the jejunum, so they have a that's a really long word, cholecystectomy, and the remaining portion of the pancreas and the end of the stomach are sutured together to the side of the jejunum. It's basically what that big long word means. So these patients are in intensive care after this procedure. We have to monitor closely for fluid replacement, hemodynamic monitoring. They're going to need to be in the ICU. So these are sick patients post-op. Okay, that is the quick nitty-gritty. I try to make this as fast as possible for you guys. Please just look over your key objectives, and like I said, look over those tables that I told you to, and we're going to do some case studies, some role playing of discharge instructions, diet instructions, different things like that to kind of help you guys pull this information together in class on Thursday. So I'm gonna end this video, and I will see you guys next week. Thanks.